We are privileged to have our second speaker, Dr. CHITRA RAMAMURTHY. She is the chairman ARC, and God has been very, partial to her. He's given her 36 hours in a day and 150% energy than normal people. And that we have seen in the last 2 years, the way she's been up and about, spreading the knowledge for all of us to become more educated. Thank you, Chitra. And today she'll share with us, what she learned in the last 2 years of, a disturbed period. Chitra.
Yes, actually, before I start my talk, the reason why I have got so terrifically energized about it all is, I realized that it's not an ordinary responsibility that has been entrusted. I have to do something that you'll remember me after my time. So I would be very happy if you all do watch few of those ARC webinars, remembering that I put my life and soul in it only for all of you. Thank you very much, Dr. Suhas, for allowing me this time. So what I learned new in cataract surgery during lockdown, I did not learn newer surgery, so I'm not showing newer surgical techniques. But I found in our practice that there was a sudden increase in health awareness. We had to just tell them toric IOL and explain they would want toric IOL. We explained Indian multifocal or for imported multifocal based on their cost possibilities. There was an increased generosity in their minds to prioritize for their health. So I thought I would concentrate on telling you how we learned to optimize in getting more premium during this lockdown period. So what is important for us to remember that when we are talking of a refractive cataract surgery, that is getting that kind of visual outcomes in cataract surgery, we need to run after astigmatism, even low diopters. And I'm sure if all of us are already doing it, then we are already there. My talk is null and void. Residual astigmatism about 0.5 diopter or less is probably acceptable, which conventional wisdom tells us. But anything more, definitely let's understand we might have done a great surgery, but the image quality definitely would decline unless you wear those spectacles. 66, if you look at the statistics of the prevalence of astigmatism in cataract surgery, it tells us that 66% have astigmatism between 0.25 and 1.25, and there we need to address it. So then, what becomes important for us to understand is, what is the most common procedure to manage astigmatism with different levels of astigmatism? So this was a way back in 2014, an ASCRS survey was done, wherein they found that there was a 42% and odd who went in for this OCCI or on-axis incision when the amount of astigmatism was low. And then gradually 13.2% or 17% moved on to LRIs and astigmatic keratotomy. Femtosecond laser had also come in a decade ago. But toric IOLs had already started peaking, but at the same time, more beyond 1.25 astigmatism, with more than 53.9% wanting it. And some more got bioptics done if there was some residual ever, and some remained with glasses. In 2021, a survey was done. It showed that 14% of them wanted for toric IOLs, even for 1 diopter, 31% for 1.5, 31% for 2 diopters, and 24% for 2.5 diopters. And this was another study. What was the cause for a dissatisfaction after implanting a multifocal IOL? It was seen that the residual refractive error was the major cause, up to 57%, followed by dry eye, which we have not evaluated. And we got very aggressive in ensuring dry eye was definitely a part of our workup, fewer in visual symptoms and few in CME or few of the intra-op complications. So then, what was also came to light was the dissatisfaction of vision. That is the percentage of very dissatisfied to okay dissatisfied at 3 months post-op was essentially the residual refractive astigmatism in the worst eye. And these are your mouthpiece who are going to go around telling you, it told us that run after this astigmatism. If you can get access to any optical biometer and you're lucky to have IOL Master 700, what has happened with the technological development is it has incorporated a swift source OCC along with the B-scan, wherein it measures the corneal thickness, the lens thickness, ensures it's always on bang-on fixation, and a 3-zone keratometry. What it does is it uses a toric model to measure the anterior corneal surface, and with the information of the corneal thickness, it interpolates the details of the posterior corneal curvature and gives you an information of the anterior corneal astigmatism and the posterior corneal and the total keratometry value. And this now gets incorporated in the 4th generation Barrett's formulae, the Barrett's universal and the Barrett's toric to become TK universal, TK toric. But remember, you can't just take this TK value, which you have measured on the optical biometer, and feed it online into any of the other formulas, because they already have a mathematical model to calculate the posterior corneal astigmatism. You would end up overcorrecting the astigmatism. Nowadays, machines have, the biometers have a central biometry, which gives you a very good anterior axial map and a total axial map, which gives you more information about the curvature. The most important thing we all have to come to understand, we have to just bunk the older formulas. The Barrett Universal 2 is there in most optical biometers or is there online. We have to use it because it gives you what we all know is we need to get to understand how close we can to the effective lens position. That is where the lens sits in the bag. If the lens sits a little forward, there is a little less power needed. Let's sit backward, more power is needed. So what these later generation formulas do is they measure many variables. Like here, there are 5 variables which have been measured. It also measures the lens factor. That is the distance between the iris plane to the principal plane of the IOL. So imagine that level of accuracy these formulas try to address to find out where the IOL sits and give you the exact IOL power calculation. Now, if you look at the Barrett suit, the Barrett universal formula is a thick lens formula. It's a mathematical model wherein it even tells you the principal plane of each IOL, because the geometry of the IOL changes with the power. It is biconvex to plano-convex to meniscus, so it tells you exactly where the lens would sit in the eye. It also, in the Barrett toric, it will give you information about the with the ruled cornea, against the ruled cornea, the posterior corneal astigmatism, and take your toric IOL surgeries to a different level. If you have Barrett True K toric, it incorporates, again, a mathematical solution with the double K solutions and gives you, because there's an alteration in the ratio of the anterior and the posterior cornea, so you need this total TK value to be incorporated in this particular formula to get exact. So now, my post-LASIK and post-RK patients, I confidently suggest premium IOLs for them. And if at all there has been an error in a toric IOL, it will tell you with the Barrett RX whether you're going to rotate the lens or you're going to do an exchange or whether you're going to do a bioptic. So we need to identify these patients. Now, if you look here, there is some amount of astigmatism, the total TK value which is there, significant astigmatism is there. So then the next question you will ask, how low would you start putting toric IOL? I would say if it's with the rule, I would wait to up to maybe 1.25, 1.5, but if it's against the rule, even from 0.4 or onwards, I would tell. In fact, your machines will tell you whether it's a non-toric, like for 0.9 with the rule, it said no toric. Whereas for a 0.88 against the rule, it tells that you use a T3 toric, and that would tell you how to plan. So this is one case which I'm showing you, wherein it is telling you that there is some amount of 0.87 and 1 diopter of astigmatism, and it tells you the different formulae to be used. But what we did at that time, we had panoptics, but we did not have panoptics toric. And I thought the astigmatism was less and did the panoptics for the patient, did a great surgery, but the patient had a small cylinder, and I told him I would do a laser vision correction. But by the time he came to me for the second eye, we had panoptics toric for him, and we entered it and did the calculations, and he ended up getting 6.6 in that eye, and then further on did a laser vision correction, and he was plano 6.6 in both eyes. Now, this is another case which was planned for a multifocal toric. Again, it is a small cylinder, 0.57 and 0.63. But again, if you feed it into the machine, because if it is an against the rule, it tells you that you need a toric IOL to be implanted. And if your patient is bleeding, we have very good Indian torics which come at a lower price. You could do this exactly and get your patient out. Even against the rule astigmatism, if it was there in this particular patient, what the K value gave us 1.14 diopters. But if you have access to TK, it tells you that it is 0.61 diopters in 140 degrees. So then you realize that you could do a toric IOL for this patient. Then you use your Barrett TK toric mode, and it will tell you how to do it. So essentially, it is very important to do your measurements accurately. Now, this was the second case where the dry eye was there, and then more than 60% of the patient with dry eye are asymptomatic, and we went wrong in our earlier days, and he had a 0.5 astigmatism in the right eye and +2 in the left eye. We should have had those danger warnings, but we didn't look at it, and he ended up implanting a 19 diopter IOL in his eye. The K values were different. It should have struck us that the measurements were wrong because it was a dry eye status, and then he ended up with a +2 diopter. Had we waited, got his dry eye treated, and then done it, he actually would have needed a +15 diopters, and we could have done a better job with this patient. Again, if you have access to central topography, you would know whether it's an asymmetric cornea which you're treating, and that would tell you whether to go in for a regular or an irregular astigmatism. Is an important information which you get. This is again another patient, which also tells you when those fuzzy LED spots are fuzzy and they're not clear, that would itself be an indication. If your standard deviations are off as it is showing here, you would also know that this is not the right way you would go into other modalities. In fact, only 70% of our patients, you could use your older formulas, they don't have dry eyes, they may get away with it. But if your SD standard deviation is more than 0.2 or more than 0.03, look for dry eye. If it is dry eye, treat it. Then do your measurements and then do a premium IOL surgery. Otherwise, if the patient has had a refractive surgery or has a KC or a PMD, not a topography, you need to do a tomography, calculate the back vertex, posterior corneal astigmatism, feed it into your toric calculator, use the latest formula, and take care of these patients. In fact, what we do in our practice is, as soon as the patient shows an interest in getting a cataract surgery done, before we touch his cornea, do even an applanation tonometer, we actually do a biometry for these patients, and then and if he has a toric IOL, the direction of discussion altogether changes. Again, with post-refractive surgery, we would the latest generation formulae or the Haigis and more. So in fact, if it is a low diopter of astigmatism, we would do if you have a femtocataract platform, we would do an astigmatic femtosecond arcuate incisions and bail him out of those situations. In fact, what I would like to say is, what I understood is, we need to identify and educate our patients, plan the right IOL for these patients, believe that majority of the patients want uncorrected vision for distance and near. Please measure your corneal astigmatism as accurately as possible, measure your posterior cornea, and always tell yourself that you're going to hit target spherical equivalent at all times. This is what I learned. I wish all of you, if you're already doing it, you have nothing to learn from me. But if you are not there, please get there, because that will take your practice to an entirely different level. And that's what I learned. Thank you very much.
Thank you. Thank you, Chitra. Very comprehensively, very nicely thought out presentation. I just want to open up the questions. Your practice, meaning your Eye Foundation, was one of on the forefront with LRIs in the past. Now with the toric lenses having come, obviously LRI has come to the background. But, and now with femto coming in, we have femto arcuate incisions. Now, in which of your femto patients would you offer them toric, or you would stay
do arcuate incision?
Yeah.
Yeah, I said I would feed them all into my biometry, find out the astigmatism, and it will tell us whether they need a toric or non-toric. If it says toric, then I would try to talk to them for a toric. But if they do not want, if it's a small amount of astigmatism and they are not keen, I'm really surprised. Since COVID, they are all keen. I have my whole list doing only premium IOLs, which honestly, it was not like that. I used to do a whole lot of single piece IOLs also. So I wonder whether that health awareness has taken peak over the other unnecessary foolish expenditures we've done in our life. I do not know. So then, if they cannot afford a toric, but they want a femtocataract, what do I lose by doing that arcuates? I would do an arcuate. I wouldn't even tell them I'm doing arcuates. I would do arcuates because I'm not going to charge for the arcuates. It's part and parcel of the femtocataract. And debulk the astigmatism to whatever extent I can for those femtocataract. But there are many patients who say they can't afford a femtocataract. It is 50,000 extra over above. But then we have all those Indian multifocals too in our practice. They are wonderful. The Indian torics are so good. So we go ahead and implant them.
So your choice, if there's no other things, it will be to go for a toric.
Toric, yes.
So, and obviously manual LRI is totally out.
Manual LRI is out, and because there is wound regression, there is remodeling which occurs. So it is